I'd like to thank our program chairs for the opportunity to speak to you today. First off, I have no disclosures. I would like to tell you a little bit about myself and my level of expertise of this topic. I've been in practice for 14 years. During that time, I've had 3 jobs. My first job was an academic job that I took at the institution where I trained. Then I took a job in a small private bariatric practice, which wasn't a great fit, and I made a significant contracting error, which I would be happy to discuss during the Q&A, which prompted me to make a lateral move next door and become a hospital-employed bariatric surgery solo. And I was essentially in solo practice for 3 years until I was finally able to build up a busy enough practice to recruit. Since that time, there are now 3 other surgeons in our practice. So there's 4 of us over a total of 8 years. So with that in mind, I'm going to talk to you about my perspective in getting and keeping referrals. You should also know I'm a child of a surgeon who just retired. I have a brother who's a surgeon, and I love talking to people, and I've been talking to people all week about what they think about getting and keeping referrals. So this is kind of a summary of those conversations and my experiences. So first off, this just is a total beautiful segue from your talk. A major thing about getting and keeping referrals is the concept of saying yes. If you want to take care of patients, you have to take care of patients. A great example of that in my community is Lee Swanstrom. Who in this room has heard of Lee Swanstrom? So Lee Swanstrom is a former president of SAGES. He is a guru in flexible endoscopy and advanced foregut surgery. And the way he has built his amazing program is Lee always says yes. I have never heard Lee say no to a patient problem. The other thing about saying yes, there's no problem too small for Lee Swanstrom. Even though he's an expert in the field, if you call him with an incarcerated inguinal hernia, he would say yes. And now this is the other interesting part of saying yes, is just because you say yes, it doesn't actually mean that you are really the person that's going to be solving the problem. So as a yes person, a big part of that is surrounding yourself with other yes people, because otherwise life is kind of miserable, isn't it? Who wants to say yes all the time? Raise your hand. One of you. Well, you're an overachiever. I know I don't like saying yes all the time. My fellows will tell you I'm the biggest proponent of work-life balance. But the only way you get there is if you can surround yourself with other people who say yes. So this is the first big concept of my presentation. The second concept, be nice. Now, surgeons are not known for being nice, right? Who thinks surgeons are known for being nice? Right, again, no one else is raising their hand. Who feels nice all the time? Well, no one's raising their hand. I don't feel nice all the time. Absolutely not. Some of the things I'm going to talk to you today about are operationally giving the impression that you are nice, even when you don't feel nice. And Lee, you just missed me talking about you. You're my favorite yes man. So where do patients and referrals come from? Do they come from a big bird in the sky that drops them off at your door in a nice, neat little package? I'm afraid not. So take and call, other physicians. If you're in a large medical group, that can be a great source of referrals. Returning patients themselves, friends and families of patients, office and hospital employees are often great sources of referral. And finally, direct-to-consumer marketing. And I'm not going to talk to you about that at all because we've had a talk about that. So taking call. Clearly, Nike really does have a good brand. For those of you who were here in the room earlier, just do it. I'm from Portland, Oregon. I love Nike. And we've seen this already today in a couple of presentations. The 3 A's of medicine: availability, that's saying yes. You need to say yes. Affability, you need to be nice about it. So when someone calls you with a problem, there are a couple different ways to respond. Now, this was brought to my mind in a really nice way when I was thinking about my favorite place to work in my hospital. It's actually the endoscopy unit. And why is that? The charge nurse in endoscopy, when I call her at 11 in the morning and I say, I want to do an endoscopy at 12:30 over my 30-minute lunch break from clinic, you know what her response is? The first response is yes. And then she tells me when she can really do it, which might not be 12:30, an hour from now when I just called. And that's actually very different from a response of saying, Dr. Halpin, I can't do that at 12:30, because then I'm having to come up with an alternate plan. But if she tells me what her availability is, we're advancing the conversation in an affirmative way, which feels very different. Now, surgeons don't talk about their feelings very much, but we all have them. And if you can learn to manage other people's feelings well, it turns out it becomes easier to manage your own. I'm not going to talk about ability. The entire rest of this meeting is about ability. Another thing about taking call effectively, one thing I would really encourage you to do as you go out into the world, if you're not already out in practice, is figure out who makes the call schedule and figure out how and when they do it. Especially if you're going to participate in the emergency room call schedule at your hospital, which when you are coming out into practice, I strongly encourage you to do that to build up your practice. If you are at a busy hospital where you are actually going to do cases and operate all night long, it makes no sense to take call either the night before a busy clinic and have to reschedule your patients. That's a really good way to piss people off. And it makes no sense actually to do that before you're going to do a bunch of elective cases. So figure out when it is a good time to take call for your practice. Add a little buffer room so that you can do cases without killing yourself. And figure out who does it. Make friends with them. If you get your requests in first, especially at my system, it's an opt-in. So those people who get their call requests in first, they get the calls on the days they want them and the days that work for them. So how do you get referrals from other physicians? An important thing to do is identify existing relationships within your potential practice. I was so lucky in my first job. Chris Egan at WashU was my partner, and he took half of the bariatric patients and gave them to me. Like, it was amazing. I don't think that's real anywhere else. You're unlikely to get that experience. But you may be in a type of closed systems where people are obligated to refer to you. But if you're not the only person doing what you do, if they don't have to refer to you, they may not. So things to do to make sure they do refer to you, when you're in an electronic health system, make sure that your name is in the queue. I know a lot of people think that maybe this is just automatically going to happen, and I'm going to tell you, in my experience, administratively running our practice, nothing automatically happens. When you tell people to do something once, I give it at best a 25% chance it might happen correctly. So you have to constantly be going through these things and making sure they're really happening the way you think they're happening. Try and refer yourself a patient and see what happens. I recently learned in the process of managing my practice that it was taking our referral manager 6 weeks to get back to a referral. That's a good way to not do any surgery, especially in bariatrics. If it takes 6 weeks for somebody to get back to you, I can tell you they've gone to the practice across town. Building new relationships is always an important part of developing referrals, especially when you're in private practice and you don't have a hostage group of medical providers. So how do you do that? When I was at WashU, one of my favorite places to build relationships was in the doctor's lounge. That was actually where all the oldest guys went to eat lunch because most of the young people were actually busy working. But a lot of things happened there. And I got a lot of work done there. I still do that at my hospital in Portland, which is a private community hospital. And there I meet neurologists, I meet gastroenterologists, I meet the hospitalists. And so when I go in there, I just march right on up to somebody who's sitting there eating lunch and I ask if I can join them. What do I do while I'm talking to them? I try and find out what problems they have that I can potentially solve, because that's what it's all about. If you can be the person that solves a problem for them, it really generates a lot of goodwill. And if you do that, they'll continue sending you patients. I recently made the mistake of butting in on the care of a patient who had pulmonary hypertension to the point that she really wasn't a candidate for general anesthesia, who had a band. And ended up having the pleasure of doing my first band removal under thoracic epidural with an awake patient. You know who else I saw in my clinic last week? Another patient with really severe pulmonary hypertension. So, like you, I'm now the pulmonary hypertension advanced laparoscopic surgeon. Other ways you can meet, yeah, I'm finding my niche. Other ways you can meet physicians, especially if you work in a smaller community, attend hospital grand rounds with the internist. They will think you are so amazing. They will have never seen a surgeon there before, and they will want to send you patients. Trust me, this stuff works. Go to your own specialty conferences. I actually get referrals, from other general surgeons. Join your city or regional surgical societies, especially if you want to have a more advanced practice, and attend the meetings. And we have a Portland Surgical Society meeting about quarterly. It's a dinner meeting. It's a much more low-key environment. It's a great way to build relationships. And finally, also get involved at your city or state level in your state ACS chapters, your AMA chapters. All of those things are ways for you to meet people. I cannot emphasize this enough. Referring should be easy. So especially if someone takes the time to personally call you for a referral, they should not have to do anything else after that. You should get the patient's contact information and you should take it from there. Now again, like saying yes, that doesn't mean you need to be the person who personally calls the patient and schedules them for an appointment, although occasionally I will be the first person to talk to the patient. You can leave that up to your own judgment. But your referring physicians really shouldn't have to do a lot of work for their patients to get to you. Once they have sent you a patient, you need to follow back and close the loop. So in electronic health records, that's fairly straightforward. There's usually an easy way to send notes back to your referring physicians. You'd be surprised at how many people really don't do this, though. Nobody likes to look dumb, and patients think that we talk and communicate with each other really well. Now, you all know that actually we really don't amongst physicians, and if you become a physician that communicates well with other physicians, they will also continue to send you patients. So electronic health records, fairly straightforward. If the referring physicians are outside of your electronic health record, you need to come up with an alternative method. And like I said before, just because you tell your staff to do this, it doesn't mean it actually happens. I had this as a standing agenda item on my weekly meeting with my office manager and my medical assistant for 5 years. 5 years. Why is that? Well, medical assistants turn over, so there's a new one every year. Anytime there's like a disruption in the force of your office, things break down. So you have to constantly work on things like this. It should also be easy for patients to refer to you. And when I was thinking about that question, I was like, why can't patients just swipe right? Where's the Tinder for doctors? And you know what? I Googled Tinder for doctors, and I found something, aside from the 20 other things about dating other doctors on Tinder, which I might look into, but so patients actually can. These websites are starting to be developed. So ZocDoc is the thing that came up. And so on Monday, when I was finishing up my slides, I typed in bariatric surgeon, Portland, Oregon, and I got like 10 or 20 providers where you could get a weight loss consultation. Now, fortunately, none of them are the other bariatric surgeons in town because I'm not on there either, but it's just a matter of time. And this is ratings-based. You can see when this provider has appointments that are available. This is easy for patients to get to you. There is another startup that's being developed called Amino. I would watch out for it. Amino is looking to extract electronic health record data and insurance data so that when patients Google you, they will know that you have done, 1,000 gastric bypasses, things like that. Can you imagine? This is particularly helpful for patients who have conditions that are uncommon. And the founder has hemochromatosis, and that's why he started to develop it. But it's coming, and it will be amazing. And I think that will really drive traffic. So finally, returning patients and their friends and family, and this also includes hospital employees, I think is really about service excellence. If you treat people well, they will send patients back to you. I don't know how many times I'm completely mortified when I walk into the room to see a new patient, and I don't remember names anymore. And I'll sit down and talk to them, and they'll be like, oh yeah, we've met before, you operated on my wife, But I see lots of patients coming back to me. So how do you accomplish service excellence? So at our institution, we use this thing called AIDET, A-I-D-E-T, which is just a schema for demonstrating respect and having good communication. So the A is acknowledge the patient by their name. Pretty straightforward. When you walk into the room, say, are you so-and-so? If they have a hard name, I ask them, how do I pronounce your name, so that you get it right. It's just a demonstration of respect. The second thing you do is introduce yourself. You think that patients know it's you, they don't know it's you. That you could be anybody, especially if you work in a system with trainees or you have a physician extender that goes in the room before you do. They're gonna think your fellow is the surgeon, not you. Now, how I've introduced myself has changed over time. My first job as an attending, I actually was moonlighting as an ER physician, and I had a patient with a bloody nose, which I hated. I really didn't feel competent to manage bloody nose. So I took a tampon up her nose and I left for an hour. And I came back and her family said, oh, we thought you'd gone to the prom, because I looked so young at the time. And so when I first started in practice, I would introduce myself as Dr. Halpin, because people didn't always know that I was Dr. Halpin, and I'm a woman, so they might think I was the nurse. Now, at the time when they thought I was going to the prom, I complained about that to my sister, and she said, you better enjoy that while you can, because it isn't gonna last. And I'm here to say it doesn't. It doesn't last. No one says I'm too young to be their surgeon anymore. So I've actually changed how I introduce myself. And when I walk into the room, I say, I'm Valerie Halpin. And I don't say, I'm Dr. Halpin. And I'm doing that quite deliberately to try and convey the idea that we are equal, and I'm not here. And I think patients actually really, really like that. The other thing we do about introductions is we have a whiteboard in our exam rooms that has the date. It says who the patient is going to be seeing. And if there's a fellow that's going to be seeing them, it also says that. We also put up a little card that has the provider's picture and a little bit about them, a little bio card that's stuck up there that they could actually pull off. And we have the medical assistant's name. I think that helps patients a lot, because your name is written down. They take the picture. They actually take the cards a lot more now that we stick them up on that whiteboard than when they were in the little, folder on the counter. So that helps. D stands for duration of the encounter. Ideally, you should tell them, how long they could expect this to be. It turns out I don't really do this in my clinic, but I do this in surgery. So when I see a patient on the morning of surgery and their family, one of the last thing that I say to them is, how do you want me to let you know when the operation is over? Are you going to wait here in the waiting room, or should I call you on the phone? And I let them choose. And then I say, okay, my expectation is when the patient leaves right here, I'm going to come out to you and talk to you sometime in between an hour and a half and 2.5 hours. And then I tell them what's going to happen if we're delayed. I'll say the nurse in the room is going to call you. I think that helps alleviate a lot of anxiety for patient families. Finally, you should give an explanation of what the encounter is going to be about and what you're going to do. And then at the end, you should say thank you. Patients don't have to come to you. And saying thank you is an acknowledgement of that this is actually a mutually beneficial relationship. They're giving you a job. They're going to be paying you. And so thank them for their time. If you're running behind, you should be thanking them at the very beginning for waiting. Acknowledge when you're late. It's just incredibly important to manage expectations. Service excellence, patient calls. Wow, I just can't emphasize enough about this one either. You need to have a way to promptly and reliably answer patient phone calls, because people are really anxious about having surgery. As you do this, when I first started my practice, I would actually do this myself. I don't do that anymore. I now have a lovely nurse that does that. But as you are answering patient calls, you can develop clinical protocols so that even your medical assistant can answer your most routine and basic calls, and you don't need to be bothered by it, but your patients are getting great care. The other thing I did in the beginning of my practice, which I learned from Mike Brunt, another former SAGES president, who, by the way, does have the sweetest practice in the world with, I swear, just left adrenals, minimally invasive parathyroids, and Nissens. Like, who knew? Mike Brunt has a tasty, I call it the tasty morsel practice. When Mike started in practice, he would do follow-up calls with the patients and follow-up calls with their referring physicians. And so I did that my first couple of years in practice when I wasn't really that busy. And I would just take time to do that. That's a good way to connect with referring physicians so that they know you're in the community. Realistic scheduling. Are any of you familiar with this picture here? This is called waiting. It's a public art installation here in Seattle in the Fremont district, and it's commonly dressed up in clothing. So every time you see it, it may look a little bit different. I would encourage you to go see it. It's a great little neighborhood. When you transition from your residency or even from an old job to a new job, you can count on that it's going to take you a lot longer to do whatever you did before. So that gallbladder that took you 30 minutes in your residency, let's say maybe an hour and a half, even a straightforward one. So plan on that in the beginning. Like you said, the nurses talk. Nobody likes the slow surgeon. But if you schedule realistically, they'll at least be a little bit more tolerant of it. People also don't like waiting for you. Newsflash, do any of us like waiting for anybody? No. And you know what? Turns out the data shows that actually men like waiting even less than women. They're much less tolerant of it. So as we see some demographic changes in the community where men have the potential to be more care providers in joining their family members in office visits, they're going to be less tolerant of waiting for you. So if your clinic is always running 2 hours behind, I would suggest maybe that means you should be scheduling your clinic differently. You know, none of us are really that great. And finally, the last thing I'm going to say is learning to manage your emotions is incredibly important. None of us feel good all the time, but everyone around us deserves to be treated well all the time. So figuring out how to treat people well when you don't feel well is incredibly important. Some of these things, managing your schedule, taking call when you can, will help minimize those times when you don't feel well, and it'll be easier to behave well. But I can't stress this enough. It's something I feel like we don't talk about very much as surgeons, but it's incredibly important. I would encourage you, if you struggle with this, get professional help, get coaching, do whatever it takes. The people who aren't behaving well often don't know how many referrals they're not getting because they're a jerk. Like, you don't know you're not getting. Like, if you treat somebody badly, they just don't send you those people. And that's the last of my slides. Thanks.